Right. I will read this. MBBS stages, general surgery, individual, okay. And now we will go. I will introduce him.
Your voice.
Your Sarah is rejoining, sir.
I think there is some issue with the connectivity.
Yes, sir. Yes. మీది వాయిస్ రావట్లేదు సార్ అందులో కొద్దిగా ఇప్పుడు ఒకసారి ట్రై చేయాలి సార్. నేను క్లోజ్ చేస్తున్నాను డైరెక్ట్. సార్ మీరు చదువుతారా సార్? అది అవసరం తీసేనా అది? సార్ లాస్ట్ లాస్ట్ సార్.
Hello. Hello. Can you close the screen?
ఎస్ సార్.
Yeah. Can we go on live?
ఎస్ సార్.
Yeah. Can you go on live?
ఎస్ సార్. ఎస్ సార్. ఎస్ సార్. వీఆర్ ఆన్ ద లైన్.
Yeah. Dear Pure Urology viewers, good evening, one and all. Today we are talking about every urologist who will aspire for beginning transplant. It is urologist means before joining urology, it is about transplant program. Everybody likes to do renal transplant, but it is a teamwork. The nephrologist has to be there. The hospital has to be there. Transplant team has to be there. To talk about this, Dr. Abhiyutthan Singh today will give presentation how to develop your career as a transplant surgeon. So I will introduce him. We will share the screen and then I will hand over the program to him. So today Pure Urology talk is, can you share the screen?
ఎస్ సార్.
So video-based surgical presentation on path to become an independent renal transplant surgeon for young urologist, Dr. Abhiyutthan Singh. Today, he is did his MBBS from Seth GS Medical College and KEM Hospital, Mumbai, DNB General Surgery, PD Hinduja, Mumbai, MCH Urology, SPMC Rajasthan. He is Assistant Professor Renal Transplant and Urology Institute of Liver and Biliary Science, leading the renal transplant program in ILBS New Delhi, Associate Consultant Indraprastha Apollo Hospital, New Delhi now. Associate Consultant, Senior Resident PD Hinduja Hospital, Mumbai. Achievements in the field of renal transplant. transplant dual en bloc adult kidney in MIDGET recipient, deceased donor pelvic ectopic kidney retrieval and successful implantation in the recipient, youngest surgeon of India to lead a renal transplant department at an premier government institute of Delhi. And he also specialist interest in deceased donor cadaveric donation awareness and helping institutes in setting up retrieval center and increasing the number of cadaveric organ donations, multi-organ retrieval training programs. So with this introduction, Dr. Abhiyutthan, thank you very much. Over to you, please.
My voice audible, sir? Good evening, sir. Thank you for giving this opportunity. Let me start sharing my screen now.
Yes.
I'd like to thank this platform for giving the opportunity for me to. My topic for today is a path, a sort of for a renal transplant, to become a renal transplant surgeon for a urologist who is aspiring to do so. Starting with, whenever we are thinking about it, then the question comes are how I get trained for this, where do I go for to get trained for this. When I'm completely trained or when I think that I'm trained, then when and how to say goodbye to your mentor's team, and also dealing with troubles in your new setup. Now, according to me, this is the most important question which you should ask yourself. What should motivate you to do transplant? What should motivate you to become a renal transplant surgeon? Is it the fame which you will get, or early social recognition which you will get, or money? I'm telling you, if these all are your answers in your head, then you should not go ahead with this. You should be, it should be pure love towards this surgery or the surgical procedure, which should lead you, which should motivate you to pursue career in this. Because there are many other urological surgeries which will give you more fame, money, leisure, at also being less stakes of your mental well-being at lesser stakes in those surgeries. So it's just the pure love for this surgery which should motivate you to do this. Now, why am I giving this talk? After completing my MCH, I got trained for 3 years in transplant and then I started my own transplant program at Delhi. I'm lucky enough to get an opportunity in Delhi itself. I've been lucky enough that in past 1 year, which I've done here transplant, around 56 surgeries I've done here, and I'm happy with my results. Not me, my nephrologist is also happy with my results. So, where to learn transplant? I would advise you to join a transplant center or team which is doing more than 100 transplants at least a year. This number is not vague. I am talking about 100 because we have to see all the variations and also deal with complications. See, transplant surgery is straightforward. The steps are mostly the same which you will perform in each and every surgery. But when you are getting trained, you are supposed to learn or see at least all the complications which can happen in this surgery and how your mentor is managing it. So complications are the main purpose which I want you to spend your time at a center which is doing more than at least more than 100 transplants a year. Then comes, is it a difficult surgery to perform? Not at all. I have been in part of, or I have done much more difficult surgeries, urological surgeries than transplant. Transplant is not at all difficult surgery to perform. The only issue is the stakes are very high. The stakes of donor surgery, the stakes of expectations from you from your nephrologist, as a CKD patient who is expecting his life to become normal again. So those stakes are very high. A single mistake or a small mistake of your surgical part or of your pre-surgical management or post-surgical management can ruin somebody's future. So that's the only issue with this surgery. The surgery is not difficult to perform. Then I have divided this sort of Herculean task according to everyone into few steps which you should follow whenever you are there at your training center. Donor nephrectomy, recipient bed making, achieving hemostasis in both donor and the recipient. Then as comes the anastomosis, the hyped up arterial and venous anastomosis, and the bench surgery. So I have given this task in descending order of the priority which you should give when you are at your training center. According to me, donor nephrectomy is the most important part which you should learn properly. So as any surgery which you learn, there is a proper learning cycle. First, you observe your mentor doing it, then you assist him while he is doing it. Once he is happy with your performance, when he has confidence on you, then you perform that surgery under his assistance when he is scrubbed in. Then comes the part when you perform the surgery under his observation, when your mentor is not scrubbed but available around in the OT. Then comes the part of your duty to teach that same step to your juniors. So then here comes donor nephrectomy. A properly done donor nephrectomy can hide many of your mistakes which you do on your recipient side. There are many techniques by which people are doing donor nephrectomy: open, lab, retroperitoneal, robotic. But don't go to a center which is making it into a fancy way that we are doing robotic donor nephrectomy or we are only doing laparoscopic donor nephrectomy. Choose a center not based on which way they are doing the donor nephrectomy. Your aim should be at your center is learn whatever technique your mentor is perfect in teaching. Donor nephrectomy should be safe donor nephrectomy. Your main priority should be taking out kidney while preserving all the hilum and ureteric blood supply, and your donor should not suffer any morbidity. The technique doesn't matter at all. Learn the technique which your mentor is perfect in teaching. Don't go for fancy techniques. Then comes the second step, according to me, of importance is recipient bed making. See, once you enter any transplant program, this must be the first thing which will be handed over to you as you are a urologist or becoming a urologist. That recipient bed you will be making, and you take this step for granted. You do a half-hearted job. Your main aim is to learn anastomosis. No, this should be one of the more important steps for you. A properly mobilized external iliac vein, after ligating all its tributaries, can come up to the subcutaneous level in a recipient. And then anastomosing any small renal vein, either on the right side or of the left side, is at ease. You will be able to do anastomosis with very much ease if your iliac vessels are mobilized properly. I've seen people being afraid of ligating internal iliac veins. So whenever you are in your training period, I'm not saying that each and every external iliac vein you should ligate the internal iliac vein to mobilize it. But you should not be afraid of ligating internal iliac vein. You should learn the technique of ligating all the tributaries of external iliac vein. Then come mobilization of internal iliac artery. So ligating all the branches properly, learning how to take a Y-graft of internal iliac artery is again your responsibility. It should be given more importance when you are in your learning phase. Mobilizing limited part of external iliac artery when it, of course, especially when it has a very tortuous course, so that your anastomosis doesn't hang once you have mobilized it fully. So recipient bed making should be given very much importance while in your learning phase. Then comes another important point of achieving hemostasis. So this achieving hemostasis is also given to you in your initial period of training. Don't take it for granted or on a ease. This is a confidence builder between you and your mentor. If you are able to achieve nice hemostasis in your recipients before closure and your re-exploration rate of your future cases is very low, this will give confidence to him to give you more steps of surgery. Also, as per me, I have learned using my small sutures, 70 and 80 proline, while achieving hemostasis in my teacher's cases. So whenever there used to be a small user, I never used to use Surgicel or these gel foams to achieve hemostasis. I used to take 80 or 70 proline bites over them. This not only made me more familiarized with doing anastomosis, using my needle properly, using my Castro forceps properly. So don't take this step for granted. Try achieving hemostasis perfectly in your recipients and donors also. Though there might be some days when your recipient of your teacher's recipient might get re-explored for bleeding or clot formation. Don't get disheartened by that. You did your good job. You did a better job achieving hemostasis. You gave your best. These things can happen to anyone. Then comes the height of anastomosis, number of anastomosis which you will get at some place. That center is giving 25 anastomosis to their residents per year, venous or arterial. I'm telling you, I must have repeated this third or fourth time. Don't choose a center based on number of anastomosis which you will get there. Anastomosis you will be able to do on your own once you have done 5 or 10 anastomosis. It's the same technique which you are following again and again. Why you are there at a center is how to manage if any mishap happens in these anastomosis. You have to learn how your mentor is holding the vessel, how he is not injuring the intima, how he is moving the needle inside out or outside in. Ureteric anastomosis, you will get more than enough. What matters here in your head is how much arterial anastomosis you are getting or how much venous anastomosis you are getting. I'm telling you again and again, don't go for numbers. Try to learn a correct technique of holding vessels, holding your needle properly, your castroforceps properly. And what thing which will help you in this is AV fistula creation. This is a confidence builder. If you are doing your AV fistulas perfectly, I'm 100% sure that you will be able to do your transplant anastomosis perfectly. So give time to learn this skill of making AV fistulas properly. Your AV fistula success rate should be more than 95%. That is, after 6 weeks, your CKD patient is able to get dialyzed from that fistula. This fistula creation percentage will help you once you go out and start your own center. At any transplant center, the nephrologist will start giving you AV fistulas initially. And while you are doing your AV fistula, your patient is under local anesthesia, you can build a very good rapport with him if you make a good AV fistula. That patient for sure, if you have made a good AV fistula, will come to you only and only you for transplant surgery also. Because that time he was under local anesthesia, he was talking to you while you were doing the surgery. So don't underestimate AV fistulas. These also you will get initially in your learning phase from your mentors. Always get involved in managing complications. The issue with this is most of the complications happen or the management of complications happen at midnight and you are off duty. I'm telling you, don't do your learning process as a 9 to 5 job. When you are involved in any transplant center for learning, do it wholeheartedly. Go for management of all the complications. Whatever capacity you get involved in, observation, assisting, or performing of managing these complications. But your sole purpose there should be to see how your mentor is behaving, how your mentor is managing these complications. Not only surgically, but how he managed the situation all around. How he spoke to the relatives, how he spoke to his nephrologist, how he managed the administration, because this again re-exploration and all will cost to the administration. So how he manages all those things should also be learned by you. Then comes how much exposure is enough. See, this is a very subjective matter. Some surgeons might be happy with 10 ureteric anastomosis, 15 vascular anastomosis, but this is a subjective matter. But I'm assuring you, if you have spent 3 years at a transplant center and you have performed and given your best at that center, which is doing more than 100 transplant a year, you are ready to go. Buy some life simplifying gadgets. Buy surgical loop in your initial training period only. See, there are many people who will boast that they do transplants without using surgical loop. It's not that I'm against not using them. It's just that we as young surgeons are more easily getting acclimatized to these new technologies. This is not new, but still I'm telling you, if we start using them in our initial career, then it's very easy. You get dependent on them and they're very, well, if you can see things better, then you will perform the surgery better. Don't try to not use them. You will get used to them if you start using them in your initial career. Then comes learn transplant nephrology. See, whenever you are at your training center with your mentor, don't underestimate nephrology. Learn the transplant. It's not a big thing. It's very small books are available. If everything is written, it's not like surgery that you have to perform and learn. Everything is written in small booklets. Learn TMA, rejection, biopsies, immunosuppression. See, whenever you are starting on your own at your new center, any small drop in urine output, the nephrologist will try to blame it on your surgical skills because you are new at that center. But there are hundreds of reasons for a urine output drop post-operatively other than surgical cause. Rely on your surgical technique. Your Doppler will never show decrease in blood flow. There will be hundreds of other causes ranging from TAC level to be more or TMA happening or subtle rejection happening. So learn nephrology. This will help you not to avoid becoming a punching bag when you start on your own. Next part is learn basic transplant anesthesia also when you are at your training center. You should know how much CET should be, how to read ABG, what's the bicarb level, how to correct it in perioperative period, sugars, perioperative fluid management. See, when you are starting on your own, you can't expect the management to get you a anesthetist who is trained in transplant anesthesia, having diploma in it. And also you can't expect that anesthetist to be so kind to learn your techniques of doing it or the techniques which are now being done at each and every big centers, how they manage the transplant cases from the anesthesia point of view. So you should know basic transplant anesthesia and communicate it to him in a very subtle way, nicer way, so that your patients produce good urine output on table. Transplant anesthesia has a major part in kidneys producing good urine output on table. Your anastomosis is going to be fine. These things should be should be more tackled by you. So I've given this again a priority from above to down. How much importance you should give to arterial anastomosis in your learning phase. For me, main thing is donor nephrectomy, doing it properly. Then learning, achieving hemostasis, AV fistula skills. Then comes ureteric and vascular anastomy. Simultaneously learning transplant anesthesia and nephrology. Then comes what next? Stay at your large team where you're comfortable or make your own team or start on your own. So for this, I made a small questionnaire to ask yourself few questions. First question is, are you trained enough to take stress which comes with this surgery? No matter how nicely you do this surgery, how nicely you have done the donor without trauma, how nice anastomosis you have done, but still there will be cases, there will be instances where there will be low urine output, decrease in urine output, APN. So are you trained well enough to manage that stress? If yes, then you should take your own. Then you are eligible to start your own. Next question comes is your mentor or your senior ready for your backup for initial few cases? It doesn't matter how nicely you have been trained, but I'm telling you, first one or two or three cases, your nerves will trouble you. I remember my first case taking out the kidney after finishing donor nephrectomy. My hand was shaking while I was trying to perfuse it. So nerves are the thing which you should be calm in your OT. in your initial few cases. And that can easily be done if your mentor or a senior is there in the OT setup or at least in the campus for initial 1 or 2 cases. So is your mentor or a senior ready to be your backup? Here comes how you have spoken to him before leaving your unit, how you conveyed him before joining him as for learning that what's your aim, you want to start on your own one day. So with mentor, your repo should be very nice so that he becomes your backup for your initial few cases, not initial also. In future also, there will be many instances when you will need him as a backup. Third question comes, will you be able to stay happy with limited number of cases in your initial career? Right now, when you are at your mentor's place, you must be doing 7 to 8 transplants per week. And when you go out on your own, you'll be doing 1 transplant per week, or there will be a span of 10 to 15 days in between when you are not doing any case of any transplant case. So will you be able to stay happy, keep yourself occupied? If yes, then you are ready for it. Then comes initially in your career, you will be one-man army, you will be having less trained staff, less trained according to you. They are well trained for surgery, but less trained as they haven't assisted you more, they haven't been around you in OT before this. So in that way, they are less trained. So are you trained enough to perform this surgery with less trained staff all around you? If yes, then fine. All your future leaves, holidays, vacations will be planned. Once you discharge your patient, the next patient is not planned for surgery, then only you can take the leave. So are you ready for it? Also, are you ready for being controlled by nephrologists for initial few years? Is the scenario all over India? Barring 1 or 2 places. So nephrologists will be controlling you initially in your career. Slowly, patient build up, patient trust. Your name will also build up in that institute, but initially this program will be controlled by a nephrologist. So have you learned the tactics, the ability to convey to your nephrologist, to have a good rapport with your nephrologist? If yes, then you are ready to go. If all these questions have been answered affirmatively by you, then you can start your own. Buy a few stuff before you start. Buy a self-retaining retractor, Omnitrack, Book Walter, whatever you are comfortable with. This will help you, your assistance getting simplified. After placing them perfectly, you can easily do transplant with a single nursing staff, the recipient part. Invest. Now comes question of how much you love this surgery. See, investing in your personal hand instruments, buying a single bulldog costs around 30 to 60,000. And I'm telling you, buy them. Don't compromise on buying vascular clamps. I've seen mishap happening because of these vascular clamps, because of low quality vascular clamps, vessel getting damaged, they getting slipped. So buy them. Then comes what transplant may give you after you have started your own. What transplant may give you? It may give you refined surgical skills. Your fear of large vessels, big surgeries, major surgery is gone. It will give you money also, give you social recognition also. But these should not be your primary aim. The most important thing this surgery should give you is happiness whenever you are performing it on your own, in your own setup. The happiness should be the major thing which you should achieve from it. Because otherwise, there are many urological surgeries which will give you same or more money, leisure, same, but your mental well-being will be at a lesser stake in those surgeries. Whenever you see or read news about a transplant surgeon or a non-transplant surgeon going to jail, these will hamper your mental well-being. No matter how much or you try to ignore it, but your mental well-being, if you are in this program, will be at stake. So have you learned the tactics, skills to make sure your physical and mental well-being is not being at stake while doing this surgery or this program? Legality should be on your feet. Learn Chota app. Check documents on your own. This is a famous line everybody likes. So never believe on your transplant coordinator. Have a good rapport with them. Don't believe them blindly. Never believe on your transplant coordinator. Never believe your nephrologist blindly. Check documents on your own. This is your duty to make sure that relationship is established by yourself of those recipient and donor. You are happy that they are related. You might do DNA test, whatever you want to do. But satisfy yourself before signing Form 4 or Form 5 to establish their relationship, fitness of donor. See the patient by yourself. Don't sign Form 4 without seeing the donors. There are places where nephrologist will show the recipient, a transplant surgeon 1 day prior to the surgery, both pair, the donor and the recipient. Don't do that. Might be initially the nephrologist will curse you, but you will be the only person who will be blamed if something goes bad. So legality point of view also you should learn while you are at your transplant learning center. Don't underestimate this. So in my career of this 1 year, I have done few interesting cases at my institute. I have en bloc transplanted dual adult kidneys in a midget recipient. He was around 146 centimeters. We got both the kidneys because it was having terminal creatinine of disease donor was 1.4. It was an extended donor. We did an en bloc transplant of these adult kidneys. Though it's usually done in pediatric kidneys, we did it in adult kidneys. My point of view here was because it was having two renal arteries on both sides and two renal vein on the right side. So either I had to use both the fossas, but I did it as an en bloc, and luckily things went well. This is how I placed both the kidneys. This is the recipient. If you can see, the height of the recipient is small. It was around 4 feet some inches. This is post-operative photograph after the BJ stent was removed. The ultrasound is showing both the kidneys, not much hydronephrosis, good blood flow. He's still with me on follow. I have also implanted an ectopic kidney from a deceased donor. The retrieval part was also little tricky here because we had to reflect the bowel properly without disturbing the kidney capsule, which was placed in right iliac fossa. We were not knowing where the vessels will be of this kidney, so we took it en bloc, and then on bench we removed all the extra tissue. Implantation also was an issue in this because both all three vessels, there were two veins and one artery. All three vessels were in different planes. So you can see the artery is coming from front, the vein is coming from behind. Few donors also have done here at this center, which were little out of the box. You can say I'm not counting multiple arteries here, but this was left-sided IVC. So both the side, and it was turning towards right on the at around L2 level. So both the veins were small. We still decided to go with the left. Left artery was also having early branching. That's here. So this left-sided nephrectomy was like the right-sided. The IVC was the landmark which we were following. The gonadal vein on the left side was draining into IVC. There was one accessory renal vein also, main renal vein and accessory renal vein was also there. We clipped the accessory renal vein and implanted this kidney. We were lucky to get a common stump. So I am, as every surgeon, I also had complications at this center. I'm not a perfect surgeon, or I'll say if you are doing surgery, numbers are enough, the complications will be happening to you. They are bound to happen. You are at your teacher's center, you have learned how to manage them. This happened unfortunately in a donor with me. There were two renal arteries, one smaller one was just behind the renal vein. I had clipped both the renal arteries and cut them nicely. I've doubly clipped the renal vein. But while I was cutting the renal vein, the renal vein got cut by mistake, and that was the stump of the smaller renal artery, and I gave a nick to it just below the first clip of that renal artery. There was a gush of blood. Luckily, the This was the end part of the surgery. We removed the kidney. Now here the point of training your staff. This was I think around 40th case of mine. So I gave the kidney to the guy, the nursing staff who has been with me since past all the cases and had been assisting me in perfusion. So he perfused the kidney while I put pressure and then second C clamp over this. Then the surgery was the same. After putting the second C clamp, I checked the kidney. Luckily, not, both donor and recipient went home healthy. Again, there was, I have re-explored my recipient also because of collection inside. There was some small oozer. We re-explored him, removed all the clots, and as in 99% of cases happen, we could not find the active oozer at that point. We again closed it and nothing happened then. There was no recollection or drop in hemoglobin afterwards. So there had been a funny complication also with me. Funny in the sense while this is just a pictorial diagram, but this retractor I wanted to show you, the retractor which is on the proximal and the medial aspect, which lies near the celiac. So while I was doing ureteric anastomosis, I felt that the kidney became flaccid. I felt the renal artery, which was anastomosis internal iliac artery. It didn't show any flow. I got panicked. Then I checked internal iliac artery. It was also not showing flow. Then it clicked that I have this retractor blade is pressing on the common iliac artery. Once I removed it, there was good blood flow again, kidney became pink and turgid. Urine output luckily also started again. Then we did the anastomosis. So this complication also happened to me. So complications happen. It's just that your training it should be enough that you can manage these complications. So at the end, I would like to tell, join a high volume center and a mentor who is ready to teach you. Don't run behind the number of anastomosis which you get there. There are many more important things which you should learn there. Anastomosis you will be able to do. I'm assuring you, if you are doing a good AV fistula, anastomosis won't be a thing which you should be worried about. Learn how your mentor behaves when things don't go their way. When there are complications, how he behaves with the relatives, how he manages inside intraoperatively, how he mobilizes the patient as early as possible, how he conveys the message to nephrologist, how he conveys the message to administration, because complications are bound to happen in this surgery. No one can say that they never had complications in this surgery. Always be ready to learn new stuff and make a small team of like-minded people before or after you start your own team. That's it. Thank you.
Some question. Am I audible?
Yes, so you are audible. Little cracking of voice, but you are audible.
Normally, transplantation the blood will be will say, because most they are seen by nephrologists. How to develop take yourself deciding for only or deciding which donor it is donor is correct or not.
So what I could hear from your question is how to decide which donor is correct or how to decide which recipient to take in initial career. So donor criteria are there. If donor criteria as the medical fitness are there, you can see it's not full and final donor criteria that if it's more than 70 years, then you should not take him. If he's a good 70-year donor, good means he's walking, talking, doing in all his own work. He's coming to your OPD working, doesn't have much hypertension, diabetes is also not there, his kidneys are functioning well, then there is no thing which should stop you from taking him as a donor. Also, you should be trained enough that number of arteries supplying to kidney should not be a criteria for rejecting a donor. Regarding recipients, I remember my initial few cases, I tried to avoid patients having major comorbidities other than CKD, like having CAH, major cardiac issues. Though you will be able to do them surgically. But initial few cases, I'll suggest not to take those high risk recipients for your own good, for your stress level to be low. That's all. Surgically, there won't be much difference in them. So are you there?
Do you think by performing the AV fistulae more, you will be more efficient in doing the vascular anastomosis?
Yes, sir, for sure. I'm telling you, AV fistula skills are much more important than learning anastomosis technique at your mentor school. Because it's very hard to give arterial and venous anastomosis to somebody else on your own cases. Like now I have a junior with me, so I know how my palpitations happen when I give him any step of the surgery. So it's very hard for a mentor. Though expecting, when I was with my mentor, I was expecting I should get arterial anastomosis. I have been with him so long. But his technique of teaching me, he made sure that I made very good AV fistula. He was there initial part of my AV fistula training. He was there in my OT and teaching me the steps of doing proper AV fistula. And if you are able to do good AV fistulas, I can assure any budding transplant surgeon, he will be able to do surgery, anastomosis very nicely. Because you have to learn respecting the vessels, how to respect artery, intima, how to respect vein, how to catch hold artery, how to catch hold vein. These are all things you will learn while doing AV fistula. And steps are
Okay.
same.
Yeah. What about the renal physiology, transplant medicine, and drugs? Do you think that in the present era, uh, the uh, the transplant surgeon, for example, Dr. Anant Kumar is there, who was from SGPGI, and he knows a lot of some people may know the lot of the medicines which we do in the post-suppressive treatment. Do you think that we have role to know that and keep a follow-up with the transplant patient?
Well, I've said this in the, see, you should know them. It's very easy to learn them. It's very, if a DNB first year nephrologist can learn it, he has just learned the medicine part. He is just MD medicine and he is learning it and he knows it. So why can't a surgeon know it? It will help you to
Great.
help you to protect yourself. There are hundred of reasons for urine output to fall in post-operative period, and very rarely it will be a surgical cause. So if you know that tacrolimus level has raised up, or they have given a low dose of tacrolimus, or there was a subtle rejection happening, the titers are going back again up. If in an ABO incompatible patient, there is a need of plasma exchange now. If you are involved in it, then your stress level and your confidence as a surgeon is high. You know that your part is proper. It's just the nephrology part is having some issues which can be dealt in post-operative period nicely. And regarding follow-up of the patient, so initially I won't suggest following up the patient because initial patients will be coming from a nephrologist in your career. Though slowly, few patients are in a year span also now are following up with me. It's not a big science to follow up a nephrology, a transplanted patient. There are 8 to 10 medicines, there are 8 to 10 protocols which you have to follow. I was also with a mentor who we only manage the recipients post-operatively till their discharge, and we only used to follow up in OPD. So it's not a big science to follow up them in OPD, but I won't suggest to do this in initial
Yes.
career because initial patients will be from nephrologists. And if he gets annoyed with you because you are following up his patients, then it will be an issue.
Yes. For the transplant post-operative complications, uh, do you think that, for example, after 2 months, one of my patient had bleeding leading to sudden pain, and when we went in, it was a rupture of the renal artery, anastomosis to the external iliac artery. Uh, for running a transplant in private practice, sometimes difficult complications will come, like myocardic aneurysms, may be related to the lack of appropriate sterile methods. So how much stress will be for the surgeon to re-explore?
So this issue is there. Mostly after what you are making a scenario is it's a fungal infection happening at the artery. So I have also, when I was assisting, sir, this used to be his dictum. If there is any work going on in operation theater, especially air conditioner, in condition ducts are being cleaned a day prior, then don't do the surgery next day. Make OT sterilized, wait for a day and then do. If a construction work is going on in any part of your hospital, then your surgery, the transplant surgery is at stake. That's what his dictum was. So sterilization is one of the issues, fungal infection, then explaining the patient. But I think if you explain the patient nicely, he knows it's not your fault. These things can happen to anyone. And it's just your luck that
That
it should not do in your initial career because it's easy to explain to them once you have crossed 10 or 11 years of your transplant career to explain them that this happened to me first time or the second time. If it's your bad luck, it happens in your first year of transplant career.
yeah. So what about if multiple renal vessels are there in donor? What is your, for example, three renal arteries there on the left, one renal artery is there on the right, both are equally functioning. How do you decide in your mind? This is a common question asked in private practice. Government setup is different, but private we will be worried whether three arteries, one may go into spasm, whereas right side they prefer open surgery or long renal vein length. So what is there in your mind for multiple renal arteries on the left side?
So number of arteries should not be the criteria to choose which side. The DPPA scan, if it's showing more than 10% of difference between left and right, should be your criteria. I was trained in doing open donor nephrectomy with my mentor, though now I am at my own center doing lab donor nephrectomy. The only purpose for me to shift to lab was open donor nephrectomy require a good assistance while you tie the vessels. And lab donor nephrectomy doesn't require active assistance while you tie or clip them. So that's why I shifted to lab. So I am trained in open donors. So whenever this situation comes, I do open donor nephrectomy on the right side. If kidney functions are similar on both, and there is one artery on the right and more than three arteries on the left, then I choose right side because doing open donor nephrectomy on right side, we all are urologists. It's not a big thing. Putting a second clamp on IVC and taking a cuff, though people have stopped using IVC cuff, but the anastomosis itself becomes very nice and with ease if there is a IVC cuff with the right renal vein. So my preference is always if there is not much DPPA difference in GFR and there are more than three arteries on the left, I take right side with the IVC cuff open in an open technique.
Okay. What is your favorite suture material? Is it Prolin 50 or Gore-Tex?
No, sir, Gore-Tex I haven't used yet, nor my mentor used it. Gore-Tex, robotic people have started using it. All Prolene is much more sufficient for me, 6070. 60 for rest most of the transplant, 70 for the smaller arteries, the lower polar or the upper polar artery. Or if you are making a bench surgery, pantaloon or something, then 70. Otherwise, 60 Prolene is in a whole, most of the transplant is done with that. Gore-Tex has few advantages. It doesn't have that much memory and robotic people are using it. I haven't
Yeah,
used it.
yeah. So what is your preference of stent versus no stent in ureteroneocystostomy tunneled anastomosis in transplant?
So I have been using stents. My mentor was also using stents. So it's very difficult for me to leave this habit of using stents. And removing it 2 weeks after is not an issue. Sir. The initial, and especially for an initial transplant career, I suggest you to use stents, no matter how much confident you are about your anastomosis technique. But using a stent won't harm you much. Maximum which it can give is a few cases might have urinary infection. That's what people who are not using stents are claiming that the infection rate decreases if you are not using stents. But at least your well-being, mental and physical well-being is at a good level. if you are using stents. Small leak, small mucosal leak from urine in your drain will be prevented by using BJ sensor. And removing
Okay.
them with a
In the beginning part of the career, when you are very good in both donor and recipient, is it advisable that you will do both donor and recipient yourself, keeping the very low profile assistance? Is it advisable, or you should have 2-3 urologists along with you?
So it's very hard to have 2-3 urologists with you these days, because if you have that opportunity to have a proper donor surgeon and a proper recipient surgeon, then it's a different thing. But it's just the love for this surgery that I want to do both part on myself. I have, you will have assistance also. It's just that love of that surgery that I want to do this part. I want to do this part also. And that's what is, well, from my side, this take is. If you have the luxury of having 3 urologists, one is making recipient bed, one is mobilizing donor side colon, then you just go and clip the vessels, take out the kidney and just do the anastomosis and leave rest, then it's a luxury.
Yeah. Last question. What do you think the perfusion of the kidney should be done by nephrologists or urologists? It's always been controversy for a long time. Many people say that urologists know the anatomy, so you don't want to put your finger into that.
Ideally, nephrologists should not be allowed in operation theatre. It's happening only out, which I remember. I have assisted once when I was in Kolkata. We had to wait for the nephrologist to come in the OT, then we clipped the vessel. And then he came and perfused the kidney. But it was his take, and we were just visiting that center. That's why it felt, as a surgeon, it felt bad, sir. So why should nephrologists be allowed in OT? So this has never happened to me or my mentor in our own setup. We have made clear boundaries. Why should a nephrologist be allowed in operation theatre? If he's allowed in operation theatre, then I hope this doesn't happen at my center now.
Correct. So thank you very much, Abhiyutthan Singh, and a lot of passion I'm seeing in you. I haven't met you personally. In the coming days, I had a lot of desire, but for various reasons in private practice, I do a little less transplants than my desire is, because of a nephrologist seeing the patients, full-time nephrology availability. There are multiple issues, but still we do the transplant program is there. We follow, and we have a team, 2-3 doctors. So one does donor. I do usually lab donor nephrectomy. So others will do Dr. Ramkrishna do recipient. It's a very good science, good renal science. We must be passionate, and we should feel happy that it is in the urologist's purview, and we must do and encourage the youngsters like you. It really touched the heart, and you should encourage more juniors and go for training programs and allow the juniors to like endourology, what we are doing. Let them see your passion and learn themselves how you make the anastomosis, how you make a parachute technique, how you use the sutures, vascular sutures, how you wait for the urine and biopsy of the kidney. All these things they should learn from you people. I really appreciate, because transplant surgery is part and parcel of the urology. We must remember that. I wish you all the best and continue the same, and do more and more transplants. Thank you. Thank you very much. Thoda connection problem was, sorry for that. It's all right. I'm out of station. So sorry for that. Thank you very much.